Thank you very much, everybody. We're very excited to be here today. So I'm Julie, and this is Lara. Our presentation is a bit of a tag team presentation. So we'll be talking about the data that we're using, collecting and using in our health region, but also how that data is being used to inform our program planning, both within Saskatoon Health Region, but also our community partners programming as well. So we'll be talking about the health equity approach that we're using in Saskatoon Health Region, and then we'll be giving some examples of how the data itself has been used to influence our programs in the health region. So really the health equity approach that we're talking about and that we're using in Saskatoon Health Region involves three main components. So the first is monitoring health disparities and reporting on health disparities. The second is research into the causes of health disparities, but also into what works to promote health and to reduce health disparities. And then the third piece is taking action on the social determinants of health to promote population health. So in this picture, the slope is the social determinants of health. And when we talk about taking action on the social determinants of health, what it is we're trying to do is level the playing field so that any evidence-based intervention has an equal chance of succeeding in any population group. And most importantly, anything that we do in the healthcare system doesn't widen the gaps that exist in health disparities. Also, keeping in mind that when we talk about the social determinants of health, most of these lie outside of the health system, and we can't control all of them, of course. So intersectoral action and partnerships is a really important piece of the work that we do as well. So this is the Saskatoon Health Region. In Saskatchewan, it's the largest health region with a population of about 300,000 people. Most of the population, 85%, is urban-based, but the rural geography is definitely the biggest part of our health region. We also have a relatively high population proportion that is registered Indian status, so that's 6% compared to a national average of 3%. So I'm going to turn it over to Lara to talk about the PHO within our population and public health.
Yes, and I'll clarify, I'm not a decision maker. I'm an epidemiologist and I support decision makers. So we'll just clarify that. I am an epidemiologist within the Public Health Observatory, and we support population and public health and the broader health region. We are made up of a tremendous team of people. We are very blessed with 3 epidemiologists, 1 communicable disease, 1 chronic disease, and I'm kind of a floater in the social determinants of health. And then we have an in-house GIS analyst. We have 3 database analysts and a library technician and, well, a manager, and et cetera, et cetera. So we're hugely staffed. So when people come up to us and say, oh, you're from Saskatoon, you guys get so much done, that would be, I would say, the reason why. We have tremendous capacity. We also have co-leadership provided by the chief medical health officers and our 3 deputy medical health officers. The Public Health Observatory has 4 main pillars in which we work. Health surveillance, which health status monitoring and reporting is kind of the backbone of our unit. Evidence gathering, so it's kind of looking at the evidence-informed decision-making diagram that we looked at this morning in a different way. I think one of the biggest advantages of our particular unit is that we have a research department, or research, it's not a department, within our PHO. So we have research and health status monitoring together in one place. And then we also have a policy analyst and we work with health promotion department in particular around bringing knowledge to action. So a huge piece of our work is the knowledge translation. So these 4 points here describe our main data sources for social determinants of health, the ones that I'm sure everyone here is familiar with. For Stats Canada, of course, census data is our primary source of social determinants of health indicators like income. We have employment, education, housing, ethnicity, and immigration, those sorts of things within census. We have, over the years, I guess, migrated to incorporating the deprivation index put out by the INSPQ, and I'm sure lots of you here work with the same index. We also have administrative health data from the province, so mainly hospitalizations, vital statistics. But I think one of our, another way that we get work done is that we have tremendous partnerships intersectorally. So we have access to many administrative data sets from across sectors. So we have social services, we have education, we have police, we have, we've started to use the citizenship and immigration data. So because of Saskatoon, and people say that we are unique in our ability to work together, maybe it's the size, I don't know, or just the leadership, but we do have great access to a wide variety of administrative data. So because of our capacity with GIS analysis, we also use Canada Post, postal code data, and we work with the city on shapefiles, so that's how we're able to do our spatial analysis. And then we have, everyone here I'm sure uses as well, the CCHS, and within our own department we have the Student Health Survey, which I'll talk about in a little bit. So we have, over the years, I'm sure many of you here have heard of the early disparity work that was done within our department under the leadership of Dr. Corey Neudorf. That initial analysis was a cluster analysis of core neighborhoods with core affluent and the rest of the neighborhoods as our general clustering. We have moved away from that because it wasn't as refined as we would have liked, and as I said, adopted the deprivation index. So those are our two main stratifiers for the data. The way that we also measure inequities is the use of registered Indian status for our hospitalization and other administrative health data, of course with census data as well. And then many of the surveys that I mentioned also have a self-identified Aboriginal ancestry. So of course this list goes on to include sex, what else does it include? Education, all of the other stratifiers that we use within the department. So I'm just going to show you here. So originally, this was the neighborhoods in Saskatoon, with the red being the coterminous. They are contiguous. They have 6 neighborhoods that were clustered, and then the green are the affluent. And as you can see from the next slide, this is the index of deprivation is based on dissemination area, so you can see how much more refined we can look at disparity within our community. So this work actually does take a fair amount of GIS capacity. So this is an ongoing, it's a developmental process for us to look at disparity within and equity within our health region, and not get caught up in sort of the flavor of the month in terms of how we're going to look at the data, if it's going to be core neighborhoods or disparity. But right now we're using the index of deprivation. So the original health disparity data or report looked at life expectancy, and anyone who works with data in here, forgive this graph because the x-axis should not start at 70. So just so you can see that it looks really stark. It is, the finding is stark when you look at, for instance, in 2006, 79.9% of SHR had a life expectancy for SHR was 79.9, but for core neighborhoods it was 73.4, which is a significant difference. The health disparity report went on to look at other health hospitalization and just hospitalization data, and you can see that there are very significant differences in things like suicide attempts, mental disorders, injuries, diabetes, COPD. The coronary heart disease, stroke, and cancer were not significantly different between core, rest of Saskatoon, and core affluent. So this led to a number of publications put out by, by our department, and led to then the health disparity in Saskatoon report that Julie will speak to.
So the original health disparity report was really a catalyst and garnered a lot of media attention and interest in looking deeper into what was causing these startling health disparities in Saskatoon. So what the PHO and Population Public Health embarked upon, a program of research that looked a bit deeper into what was behind these disparities, and found that health disparities were very significantly correlated with income, living in poverty. And in fact, when there was also significant disparities noted between the registered Indian status population and non-RIS people. But when socioeconomic status poverty was controlled for, these health disparities almost disappeared. So what that told us was that, in fact, the cause of our health disparities was poverty. And when framed that way, looking at the evidence, the analysis to intervention report presented 47 different policy options that could be invoked to reduce poverty and therefore to reduce health disparities. So the next piece of work was conducted in tandem with developing the health disparity report. So community consultations were conducted both before and after the report was published, asking what the community would support in terms of poverty reduction initiatives. So over 200 consultations were held with different community groups and stakeholders. As well, there was a telephone survey of 5,000 Saskatoon residents asking them which one of the 47 policy options could they support. And what that survey found is that there was significant support for options that focused on children, on reducing child poverty, on affordable housing, on educational and job training options, on intersectoral partnerships for health, and also on reallocating health services to neighborhoods that needed them most. So in response to that, the health region made health equity one of its organizational priorities. And in fact, in population and public health, we built health equity into our strategic plan as a lofty goal to actually reduce the gap in life expectancy between the most deprived and least deprived neighborhoods in Saskatoon Health Region. And to do that, built a lot of different program activities into our strategic plan, including monitoring other SHR programs and departments, strategic plans for health equity principles, building our staff competencies in population health promotion and in health equity principles, evaluating our intersectoral partnerships to see how well they were working and how they could be improved with time. And we also did reallocate resources in population and public health by establishing our Building Health Equity program, which is a program that reallocated public health frontline services into the core neighborhoods. The program has an explicit focus on First Nations and Métis health and involves a community development approach. So it has public health nurses, a community dietitian, community program builders all working together to promote health equity in the core neighborhoods. The Saskatoon Health Region also took health equity to be an organizational guiding principle, and working towards health equity by developing a representative workforce with targets for First Nations Métis employment, reallocating resources, so making the case for reallocating funding from acute care services to health promotion services, which is great to have support to do that, and also in strategic planning overall, so looking at health equity as a piece of quality improvement in our health region. So, of course, the social determinants of health largely do lie outside the healthcare system. Saskatoon Health Region worked with its intersectoral partnerships as well. So in Saskatchewan, we have organizations called Regional Intersectoral Committees, or RICs. There's 10 of them across the province, and Saskatoon has one of them. And these are funded by the government to promote intersectoral collaboration. So there is government representation from all levels of government that sit around the table, provincial, municipal, First Nations, Métis, governance, and different sectors, including health, education, justice, for instance, are seated at the table. So as part of the consultations and with the leadership of our medical health officer, who is now the chair of our Regional Intersectoral Committee in Saskatoon, the Saskatoon RIC made poverty reduction one of its strategic priorities. And that allowed the creation of the Saskatoon Poverty Reduction Partnership, which consists of a leadership group representing about 15 different organizations around the committee, around the table. And the point is not to necessarily create any new poverty reduction strategies. There's lots of great work that's happening in Saskatoon, but it's a way to leverage opportunities that are already existing. So increased information sharing and capacity building that way. So there's 3 strategic priorities for our poverty reduction partnership this year. One is a community plan to end homelessness. The second is engaging First Nations and Métis groups in poverty reduction initiatives. And the third is engaging our faith and business partners in the community in poverty reduction work, for example, through social finance initiatives. The Poverty Reduction Partnership is also committed to monitoring poverty in Saskatoon using a set of 8 indicators of poverty, but also monitoring what community progress we're making on those 47 policy options that were identified in the Disparity report.
So about 10 years ago, once again, Corey Neudorf had the idea of developing a shared information system, and at the time there weren't really any in existence, and he saw this as very much a tool, data liberation, and a way for community to be engaged and to for all of us to work together with evidence and with data. There are lots more of these types of information systems available in Canada now, but at the time, this project galvanized the Saskatoon RIC, and everyone at the table was in agreement to have these ongoing data sharing agreements. So that's been key to our work within the PHO.
Another piece of work that the Public Health Observatory was involved with was mapping food deserts in Saskatoon. A report was published in 2010 which identified a large food desert on the west side of the city where core neighborhoods are. Of course, this was no surprise to residents who were living in the core neighborhoods and community organizations who were working in the core neighborhoods. And in fact, there was a long-standing vision to develop some sort of community neighborhood center, a community enterprise center. And this dream became a reality when the doors of Station 20 West opened in fall of 2012. The Station 20 West currently houses a number of community organizations who are working on food security, on affordable housing initiatives. It also houses the University of Saskatchewan community engaged outreach and community research center. And the Saskatoon Health Region has offices there as well, including our Building Health Equity program is located in these offices. Most exciting, perhaps, is that Good Food Junction is also located in Station 20 West. So this is a full-service community grocery store that provides a full range of grocery items and household items available to residents in the core neighborhoods. The Saskatchewan Health Region is a partner on a research grant with the University of Saskatchewan that is evaluating the impact of opening the Good Food Junction on the food desert in the core neighborhoods. So stay tuned to find out if we get that funding. We'll be able to evaluate whether or not this was a successful community intervention.
So as I said, the Student Health Survey is a tool that we use within the PHO, and it collects a lot of behavioral data that I think many of you would be interested in here. It examines the health of students from grades 5 to 8, and so far we've administered it over 3 years, or 3 time periods. The bottom line is that this survey has shown that there are significant and sometimes startling differences according to the neighborhood school that you attend. So if your school is in based on the quintiles of deprivation, deprived neighborhood, then you are more likely to not have healthy weights, to not have very good or excellent physical health, to have lower physical activity levels, etc. So here are the next few slides are the findings. So there are significant differences between low-income neighborhoods and affluent neighborhoods in body mass index and self-rated health status, not in perceived weight, though, which is interesting, but underweight and healthy weight. So if you're in a low-income neighborhood, you are more likely to have be underweight and have higher percentage of overweight or obese. And then in terms of physical activity, same thing, low income, inactive and optimal activity were also significantly different between the two categories. And then nutrition variables. We have how often, so food security, how often do you go hungry due to lack of food, and frequency of fruit and vegetable consumption and fast food consumption, all significantly different for the two different groups.
So the results of the Student Health Survey, as well as the Health Disparity Data Report, galvanized interest in doing something in schools for children. There was strong support in having interventions that were school-based and interventions that address some of the disparities around physical activity and mental health in schools. So membership of the School Health Committee that was formed in 2008 include representation from health and the education sectors. And there was a lot of discussion around what the right approach was to address the health disparities. And it was thought that a matrix approach would be best. So of course, all students could benefit from health programming in schools, but the schools that would benefit the most and an approach that would not exacerbate the health disparities would be to be targeting on low-income schools in core neighborhoods. So with that in mind, there was a pilot project where after-school programming for physical health and mental health interventions was implemented in 5 core neighborhood schools. A literature research was conducted to determine what interventions would be the most effective. And since then, our Health Promoting Schools program has expanded to include 20 schools that are complex needs schools as determined by the sociodemographics of the neighborhood in which the school is located, but also what the students' health needs are based on results from the Student Health Survey. And with funding from Public Health Agency of Canada Innovation Grant, we were able to expand that to 20 schools, and then in phase 2 of the grant, looking to expand that to other sites across Saskatchewan, other partnerships across Saskatchewan, but also with Vancouver Island Health Authority as well. Knowledge translation and evaluation has always been a strong part of our health promoting schools work as well. And in 2012, we did a survey of our knowledge user partners, asking them how they were using the student health survey data. So surveyed 150 knowledge users, had a response rate of 33%, and 2/3 of our respondents said that they were using the health survey data to develop their programming in the schools, to determine and to plan programming for the schools themselves. Keeping in mind, though, that health promoting schools programs have sometimes been critiqued, even though they include representation from health and from education, and students and parents and community partners have limited impact on the environment outside of the school setting. So with that in mind, the Health Promotion Department in Saskatoon Health Region, in parallel with Health Promoting Schools program development, undertook a community education campaign on social determinants of health and how poverty was an underlying cause to social determinants of health. So the poster you see here was one of 4 billboards that were developed as part of that community social marketing campaign. And we also developed a school curriculum toolkit for use in the middle years. So the same age group that was targeted by our Health Promoting Schools program also developed an educational toolkit for schools in more affluent neighborhoods. So where students may not have a lived experience of poverty, their families may not have a lived experience of poverty, but the educational toolkit is intended to create that understanding through in-classroom and take-home activities that students can do with their parents as well. So the curriculum toolkit was piloted last year and looking to unroll it to more schools this year.
As I mentioned, the health status reporting is key to our work, and our latest health status report is an early years report. Basically, we found, of course, that children in the Saskatoon Health Region are generally very healthy. But if you were to look at sub-regionally and by neighborhood and by registered Indian status, things are considerably different and that huge disparities exist. The key indicator that came out of our report, that's actually a provincial Ministry of Education data set, is the Early Development Instrument, and I think that probably many of you here are familiar with the EDI. And this is sort of the feedback that we have, the way that we do our work, in that out of the early years report, basically our stakeholders identified this as being a very significant indicator, and so now back in the PHO, we're incorporating it into our core set of indicators that we monitor regularly. So that's just illustrates a bit of how we develop our set of indicators. So the EDI, as you can see, is broken out into 5 components, and the overall scoring low on one of those 5 components will identify the child as not ready to learn. So within the city of Saskatoon, by neighborhood, we have a disparity from 12% in some neighborhoods to 67% of children not ready for school, or I guess readiness to learn is not quite there. It's administered in kindergarten by kindergarten teachers. So it does have a physical health and well-being component, and food access and coming to school hungry and that sort of thing is a part of that component. So massive disparities at a very young age. The other aspect of our report was, and this is how we have developed our health status reporting, is not just reporting the data, but also doing fairly significant stakeholder consultations throughout the process, having stakeholders respond to our preliminary findings, and having that feedback for many, many months. This report, I think, took about 1.5 years, in terms of completing all the analysis and also the community consultations. So these are just examples of the key consultation findings, and Julie will speak to the third component of our health status reporting.
We always have recommendations, and our recommendations are targeted both towards the health sector, but also towards our intersectoral partnerships. So what was recommended was the development and implementation of a provincial early childhood health and development strategy. And you'll note that data collection and reporting is an important piece of that intersectoral action. Robust monitoring tools, but also using health equity data for target setting, which was done with consensus around a key goal. So reducing the number of children not ready to learn from 30% to 18% by 2018. The recommendations targeted towards the health sector. We're developing more integrated client-centered services across public health, but also with our acute care and primary care partners. Of course, bolstering health promotion interventions and working with our partners to better protect children from environmental health risks.
Another component of our work is the healthcare equity audits. We've completed, I think, about 4 or 5 equity audits to date. The diabetes one, I think, probably having the most significant uptake by the service providers to date. And you can see that in Saskatchewan and in Saskatoon health region, diabetes is a fairly significant health issue, and there, in terms of prevalence, there is tremendous disparity between RIS, non-RIS, and also low-income and affluent neighborhoods. So diabetes mortality is also significantly different among those same groups. So the diabetes, or the healthcare equity audit, is a ratio of need to service. So this graph describes affluent neighborhoods, affluent need, affluent service, middle income need, middle income service, and core need and service. And so the service to need ratio is significantly different between affluent and core. So the core neighborhood, residents of core neighborhoods do not have equal service for equal need. They have less access to services or barriers to service, and that's what then the health or the chronic disease team takes this healthcare equity audit and will, they've actually incorporated the results into their work plan, so that it's a really great example of the data directly affecting service delivery.
So like Lara said, the data was just one part of what we call our healthcare equity audit cycle that has been used by many departments in Saskatoon Health Region. So diabetes was one of them, but dialysis services, mental health, looking at length of stay for attempted suicide was another example. So using data to look at the problem of the cause of the problem, using data to identify what evidence-based interventions are available, to implement the intervention, and then of course to measure and evaluate the impact of that intervention. So the Public Health Observatory is actually working on a healthcare equity audit guide, which outlines the cycle, but also identifies evidence-based interventions that departments can consider when deciding what to do about disparities that have been uncovered by this analysis. Which is quite exciting. It's a really neat example of how health equity data is being used to shape the entire healthcare system to be responsive to health equity. And indeed, the healthcare equity audit cycle, we're working towards integrating it with quality improvement processes that are already ongoing in the health region. So it's a really nice synergy and definitely complementary to healthcare quality. So we'll talk quickly. I know we're running short of time, but we'll just talk about some of the challenges and success factors that have been associated or part of our work.
So in the monetary challenges to monitoring and reporting is anyone here who does this work knows it's the data and the lack of data, the time lag between data collection and reporting, the fact that data doesn't capture certain segments of the population. The fact that we can't actually access the data that we need when we need it. Some technical complexity, as I mentioned, with something like community view. Privacy issues, that's not so much an issue, of course, at population health level reporting, but we do have the research component to our team, so they run into more privacy issues. And then, of course, around any sort of evaluation that we do within the department, attribution is also a difficult thing to identify.
Of course, the action on social determinants of health has not been without its challenges either. One of the key challenges is being able to convey the message in a constructive fashion. So there had been lots of community reports talking about how bad things were in the core neighborhoods in Saskatoon, and we really wanted to avoid having our health disparity reporting being labeled as just another report showing how bad things really were. So that's why community consultation was such a key part of developing the report, developing the recommendations, but then also communicating the message effectively. We recognize that the health region did have a bit of a credibility issue when talking about issues that really lie outside of the health system. Working with many partners, community partners, to make sure the message was coming from many voices around health disparities are not just a health issue, it's an issue that affects all of us, and in fact the real problem is poverty. Involving people who have a lived experience with poverty was also really important in this work, but of course there were challenges associated with that, and some of the strategies we employed were using things like childcare or transportation vouchers to get people able to participate in community consultations. There also was a sense of grieving with this organizational change. So in population and public health, our public health nurses actually did give up doing some things that they felt were important and of value. One example being parenting education classes. It was felt that the way we were doing it was not in a way that actually promoted health equity. And in fact, the people who were taking up our parenting programs were probably the people who needed them the least. So by allocating our public health resources to core neighborhoods, there was some, I guess, pushback around that, and the grieving process around that was something that we had to work through. Having strong leadership and support from senior leaders in our organization made that change go more smoothly, of course. And always a problem with this work is balancing the tension between community programming, where people want to get involved and do something tangible, project work in the community around poverty reduction, and balancing that with what really needs to happen at a government and a policy level to really make those big systemic and lasting changes. So trying to get people to see the connection between what they're doing as an individual around community project work, but making sure that that work is linked to advocacy around the bigger policy change that needs to happen. So success factors, I think we've mentioned this a few times in our presentation, was really the strong leadership that we have in senior leaders, both in population public health, but also in our health regions. For instance, our CEO in Saskatoon Health Region is a strong supporter of population health and health equity. The research component is so important about providing the credible evidence, and having that data shown at a community level has really been powerful as well. It's been a good way to engage our community partners to put the data back into their hands, and they can use that in their advocacy messaging as well, which has been really powerful to have more voices singing the same song. Relationships cannot be emphasized enough, and early engagement of stakeholders to build those relationships and trust. Saskatoon has a reputation of being a can-do city and a birthplace of Medicare in the province of Saskatchewan. So there is public support for poverty reduction initiatives, which also does go a long way to promoting a multi-sector approach to a common problem. And timing and patience. So it is sometimes opportunistic work, and we are well-resourced, but we certainly don't have the resources to do everything at the same time. So being able to phase in different interventions, and also being patient enough to stick with something until we can see that the evidence shows that we're making a difference, is also something that we are cognizant of. So, with our research and reporting on social determinants of health, we've been able to take some great steps towards promoting health equity in our Saskatoon health region, and that's our takeaway message for you is evidence, action to equity.